Okay, so we'll come back to the pharyngeal posturing techniques when we get to pharyngeal deficits. Let's get into some discussion of strategies for oral deficits, such as difficulty with bolus manipulation, difficulty with AP transit. Here is a list, but we're going to go through these individually. One thing to keep in mind is any strategy that you want the patient, any strategy that you put into place that you want the patient to be able to do, they're going to have the memory to remember to do it every single time. So most compensatory strategies outside of those of diet modification, those compensatory strategies that require the patient to do anything, anytime you're requiring the patient to do something themselves, then they have to remember to be able to do that when you're not around. So, as this slide says, most of these strategies require the patient to have appropriate cognitive abilities, or at least a good caregiver that's going to be there the entire time to give the appropriate cues. Here's a list of some strategies for airway protection. We've already discussed supraglottic swallow and supraglottic swallow in the form of using these for rehab exercises, but they also work well for compensatory strategies for airway protection. So the supraglottic swallow, put the bolus in your mouth, hold your breath, swallow, and then start your respiration again with an expiratory cough. That will allow you to clear the airway. And you'll probably need to tack on a second swallow onto that with the supraglottic or the supraglottic swallow, which, to remind you, is just the supraglottic swallow, but paired with an effortful swallow to go with that. So probably you're going to have to pair a second swallow with either of these, because if they do expel something out of the top of the airway, then they're going to need to swallow that. Pharyngeal expectoration. This is the sound you make when you're like hawking up a loogie. This is that sound. The sound that you make when you have stasis or something in your pharynx and you're trying to expel it back into the oral cavity, for maybe to try to swallow it again or to spit it out. And you can also teach your clients to do vocal quality checks on themselves, or you can teach the caregiver to do vocal quality checks on their loved one, which is essentially usually is going to look like after the patient takes some liquid. Either the patient independently to check the quality of their voice, to see if they can hear any wetness on their voice, or teaching the caregiver to do that, to elicit that from the client and check the client's voice if the client is unable to remember to do that himself. So we do modify diet consistencies. And if you can avoid this, you want to avoid it. Although we do use it all the time and we have to use it all the time. But if it can be avoided, you want to do your best to avoid it. More often than not, it can't be avoided. But even when it cannot be avoided, you want to try to make that as short-term a fix as is possible. So patient has a stroke. You see him in a hospital the next day. There is no possibility of this guy taking thin or nectar-thick liquids by mouth anytime soon. There is no possibility of him taking regular consistency food anytime soon. So it's fine to do what needs to be done in that moment, which would be patient has to be on honey thick maybe a mechanical soft, maybe a pureed diet. Because the only other option is that guy going on a feeding tube to make it through his rehab, and you don't want that. But in this situation, you want to put those into place with understanding that you're going to work him out of it as quickly as possible. So let's talk about use of the chin tuck strategy as it applies to oral motor inefficiency. In this case, premature posterior spillage. So patient, if they put the bolus in their mouth, if their head is level, if they're likely to have premature posterior spillage into the pharynx, then you want to train them to, once they get the bolus in their mouth, assume the chin tuck position and masticate with their head down. And this allows gravity to hold the bolus anteriorly in the oral cavity, and it keeps it from spilling posteriorly prematurely into the pharynx. Some patients can just keep their chin tucked and can do AP transit successfully with their chin tuck and swallow with their chin tuck, and maybe they even need the chin tuck at the pharyngeal level. Some patients don't need the chin tuck at the pharyngeal level, in which case, once they have finished masticating the bolus and they're ready to swallow, you will teach them to raise their head and then go for the AP transit and the pharyngeal swallow with their head in a more level posture. So as I've already said, a lot of the patients you're going to be working with are going to have difficulty recalling what strategies they're supposed to be using. The elegant thing about the chin tuck is sometimes you can arrange the environment such that it will cause the patient to do a chin tuck even if they're not thinking about it, even if they're not capable of recalling it. One of these strategies is putting their tray very close up against them right here, so they have to look down and then feed like this. You could roll up a towel, put a pillow behind their head once they're already very upright, and that is going to encourage the chin tuck position. You could have them, if you're pushing the tray up, you could have straws in their cups, and a straw is going to facilitate a person to put their chin down and swallow. But as I've already said, straw, more often than not, 9 times out of 10, a straw is your worst enemy as the speech therapist in a nursing home or acute care. So you really have to be careful and be sure that the patient can handle a straw. Counter indications for putting into place a chin tuck for oral level stuff is anterior spillage, right? So if they have a weak anterior seal, then cueing them to put their head down is going to be a bad idea because everything is just going to spill out. All right, so let's talk some about modifying liquid consistencies. Thickening the liquid helps individuals that have reduced ability to control thin liquids, because the thin liquids move super fast and then they splash and go everywhere. So the thickened liquids allow for the patient to have greater control over the liquid bolus because it's going to be moving slower. It's going to be more cohesive, so it's going to stick together as it moves through the oral cavity and the pharyngeal cavity. But one problem with thickening the liquids is that if stasis is a problem, then they're going to struggle with the thickened liquids more, oftentimes. Not always. So you're going to have to do a lot of patient education, family education, caregiver education when you go to thickened liquids, because no one outside of a speech therapist has ever encountered the idea that someone is going to come in and tell you that you have to start drinking thickened liquids. So you're going to have to explain it to the patient, you're going to have to explain it to the family, and they're going to have to understand it so that you have buy-in. Because if they don't understand why you're recommending it, they're not going to adhere to it. And this can be a difficult thing to adhere to. You're also going to have to tell them where they can buy thickened liquids, that they can buy the thickening agent at the drugstore. They're not going to know this. And you're probably, if that patient is going home on thickened liquids, you're going to have to show the caregiver, you're going to have to show the family and maybe the patient themselves how to appropriately mix the consistency, the target consistency that you're recommending. The next step in that is, after you have demonstrated for them how to create the certain consistency that you're going for, would be giving them the materials and have them demonstrate it to you so that you know that they know how to do it appropriately. Anytime you change the consistency of a patient's liquids, you need to have the idea of dehydration on the forefront of your mind, which is to say that even though you want the patient to be able to safely swallow their liquids, you also want them to be able to take enough fluids in the day to stay appropriately hydrated. This usually doesn't come into play, but sometimes it can. The next postural strategy we're going to talk about it's the opposite of the chin tuck. It is the neck extension, also known as the head up position. You're not going to use this very often. Like chin tuck, you're going to use chin. If you work in a nursing home, you're going to be teaching chin tuck all day long. Neck extension is something you're going to do one time for every 49 patients that have chin tuck. You're going to do neck extension. So you don't employ it that often. And the reason is that, obviously, if you're going to raise the head up, the patient has to be, they have to have an intact pharyngeal swallow. Because when you raise your head up, you're going to be casting that bolus posteriorly to the pharynx. So you're using gravity to move the bolus posteriorly. So this is done to facilitate AP transit, and it can be done with individuals that have motor deficits that keep them from having appropriate AP transit, such as ALS patients, patients with a significant motor deficit, or, as we've already discussed, patients that have some form of oral cancer, or perhaps like glossectomy patients, patients that have no tongue. This is the kind of strategy that is going to be useful for them. Oftentimes, your patients, your stroke patients, your TBI patients, this is going to be counterindicated because they're going to have problems at the pharyngeal level. So if you have any pharyngeal level problems, especially like a delayed swallow, the last thing you want to be training that patient to do is to get the bolus in more quickly. So if you are going to employ a neck extension, this is something that you evaluate very closely to be sure that your recommendations are going to be appropriate for the client and are not going to put them in peril of aspirating. So one way of getting around the fact that your patient doesn't have the appropriate attention or memory to hold it in their head and use the strategies that you're wanting them to use is to have some sort of external reminders for them. This can be something as simple as a sticky note that is placed on their cup, a sticky note that is placed on the tray. You could have, as we've already said, caregivers could be the ones giving the verbal reminders. Okay, so to reiterate real quick, we had the supraglottic and the supraglottic swallow, pharyngeal expiration, pharyngeal expectoration, and vocal quality checks as volitional airway protection strategies. So airway protection strategies that you can teach the patient and either have the patient do independently or have them that strategy listed by a caregiver. We talked about thickening liquids to allow the patient to have more oral control of the bolus. It's going to keep the bolus together better. It's going to reduce the possibility of posterior spillage with the thickened liquids. We talked about chin tuck, which will allow gravity to hold the bolus anteriorly to reduce premature spillage. We talked about neck extension or the head up position to facilitate AP transit. And we touched on strategies that you might try to put into place to facilitate the client's recall of the strategies that they're supposed to use. The lingual sweep maneuver is exactly what it sounds. You're training the patient after their swallow to use their tongue to gather stasis from the buccal cavities, from the oral cavity, and then to safely clear that stasis, get it out of the oral cavity. If the patient's tongue is too weak to do this, you can teach them to use their fingers to do it. Oftentimes, you'll see a lot of oral stasis in patients that have the lingual weakness, but also the decreased sensation from the tongue. So not only are they unable to really move their bolus appropriately, but they're not sensing when parts of that bolus are getting into places where it's not supposed to be. So if the patient isn't able to do a finger sweep, then the speech therapist or the CNA or the caregiver, whoever is there, will be doing the finger sweep. If the patient is able to do the finger sweep, then that's a step even better. If they're able to do lingual sweep, then that is even better. And if they're able to do the lingual sweep with a verbal cue from the caregiver or the nurse or the speech therapist, that's even better. And if they have the appropriate cognition and memory to be able to independently recall and use the lingual sweep, then obviously that is even better. Although if they do have a lack of sensation, then they may need a mirror placed close to them. So while they're eating, they can turn and check their oral cavity, check their buccal cavities to see if there's stasis in there to do the sweep for. Cyclic ingestion, also known as alternating sip and swallow, is a nice strategy that we use to teach patients to clear stasis out of their oral cavity and also the clearing stasis out of the pharyngeal cavity as well, if they can handle that, because at that point you have a mixed consistency situation going on in the pharynx. If you're taking a thin liquid, for instance, and trying to wash down a solid bolus, and that can be problematic for some patients. But for other patients, that thin liquid can facilitate movement of that bolus through the pharynx into the UES. So cyclic ingestion, alternating sip, swallow. This is a strategy that as SLPs, we recommend a good bit. So chin tuck, effortful swallow, alternate sip, swallow. What you'll find is once you get out and start practicing, for every patient, you'll probably recommend 2 or 3 different strategies that will all come into play that'll allow the patient to appropriately take their food as safely as possible, as efficiently as possible. And your recommendations will come in lots of different shapes and sizes, but chin tuck, alternating sip swallow, and effortful swallow, these reoccur quite frequently in your recommendations because they are very effective. But once again, the patient either has to be able to remember to do this himself, or he has to have someone there telling him, cueing him to use this strategy. And as I think I already mentioned, alternating sip swallow, this is a strategy that is really going to be used. I'm not going to say always because there's always an exception, but usually this will be someone that is capable of tolerating thin liquids because it's those thin liquids that they're able to use to clear the stasis so effectively. You can imagine how difficult it would be for someone with, we'll say, a lingual weakness, trying to clear oral stasis, solid oral stasis, out of their mouth with nectar thick or honey thick liquid. That's just going to be, you're just going to be making the problem that much worse. They're going to have far more oral stasis after trying to clear their solid stasis with that thickened liquid. So cyclic ingestion is something that we usually do with thin liquids. So obviously, if a patient is incapable of handling thin liquids, this isn't going to be an option for them. Another strategy we use often is referred to as the second swallow, and is exactly what it sounds like. Patient swallows their bolus, and then you teach them that after every, we'll say, swallow, or maybe after every second or third swallow, they do another swallow, a dry swallow, to clear any stasis that is going to be in the oral cavity or is going to be falling from the oral cavity into the pharyngeal cavity. But one thing to keep in mind with recommending second swallow or putting a dry swallow, every 2 or 3 boluses, is you have to consider how much this is going to slow down their taking of the meal. So, and I've mentioned this in class, but you can make a million recommendations that if the patient used them all, they might be able to take food appropriately with 0 risk of aspiration or penetration. But if it takes them 2.5 hours then to eat their meal, then that's not functional. They're usually not going to be able to do that, or at least it'll depend heavily on the facility in which they're in that will dictate whether or not they're able to do that. So you have to keep in mind with all the strategies that you're recommending, not only how is this going to facilitate the remediation of the problem, stasis, aspiration, penetration, whatever, but how is this going to affect overall their ability to take their meal? Because your recommendations can be pushing them into sort of a non-functional eating situation. Some patients are, particularly your traumatic brain injury patients, are simply too impulsive to, like, they may know that you want them to slow down and take the food more slowly and to do a second swallow, but they're just too impulsive to follow your directions. A couple of different ways you could deal with that is you could have the patient, after every bite, he has to put the utensil down and have his second swallow then. And that procedure that you're putting into place that is tactile, that is procedural, his mind is going to be better able to grasp onto that and not rush past that than he would be if he was just eating and you're there trying to say, no, slow, 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 slow. So you could have this situation where you're saying, rather than just trying to slow him down with him largely ignoring you, you could have it where he feeds himself, and you could even hand over hand have him, okay, put down your spoon. Okay, swallow. Okay, pick up your spoon. Go again. Another thing that I've seen, and it could work for some people, but it's not going to work for a lot of individuals, is like if you have a patient eating from a bowl or have a plate, then you have an empty bowl or a plate. And so for every bite of real food they take, then you have them take a bite of the imaginary food and do their second swallow then. Problem I see with this is that it's just going to confuse the heck out of people with significant cognitive deficits, like your TBI patients, your dementia patients, that may have just no idea what you're getting at. But then again, if they're able to adhere to your suggestion and do it anyway, then it probably doesn't matter that they're confused in that moment. If it helps them achieve the second swallow and clear their stasis out of their oral cavity, out of their pharyngeal cavity, making them at a lower risk of aspirating that pharyngeal or oral stasis later on. So now we've made it back to bolus placement. So for patients that have a decreased sensation to the oral cavity, that have weakness of the tongue, or maybe some oral cancer patients, like I've already mentioned, that have perhaps had a glossectomy, then you, the SLP, finding out where the best placement of the bolus in the mouth for them that is going to facilitate and perhaps cue their swallow reflex, but then facilitate their best ability to manipulate the bolus in the oral cavity. That's an important thing. And then if they can handle that responsibility themselves, teaching the patient where to place the bolus in the mouth. And I can imagine this happening with your glossectomy patients, with your oral cancer patients that don't have a ton of cognitive deficits. I could see that they would benefit from you instructing them on where the best placement of the bolus is going to be. And they might even be able to figure it out themselves. But your TBI patients and maybe your dementia patients, they're not going to be able to figure that out themselves. And so you're going to be there educating them on that. And also, when you place the bolus, oftentimes cueing, if they have decreased sensation, you can push down on their tongue at that point with their spoon. So even if they have decreased surface sensation, you're giving them that deep pressure sensation. Or you can have a cold spoon so they at least feel the location of the spoon by the coldness of the spoon. So there are things you can do to facilitate the patient's recognition of where you're putting the bolus. All right, so we often also make recommendations for the size of the bolus. And this is going to vary according to patient needs. But if you have usually And there's no hard and fast rules, as the slide here says, but usually if we were to make some generalizations, it would be that oftentimes patients with oral motor control difficulties, such as lingual weakness, a smaller bolus allows them to have greater control over it and reduce the spillage into the buccal cavities. But for patients that have reduced oral sensation, perhaps reduced lingual sensation, then a larger, more solid bolus, they're going to be able to feel that in their mouth. And that feeling is going to trigger their swallow reflex more successfully. Because if you can't feel the bolus in your mouth, and if you can't feel the bolus moving posteriorly, it is that sensation of the bolus moving posteriorly that cues the swallow reflex. If you can't feel that, you're going to have a delayed or absent swallow reflex. And also, you could have patients that having the larger bolus in their mouth facilitates their awareness that there is a bolus in their mouth and that they do need to swallow it. Some patients, such as those with dementia, will reach a stage where you could put a small bolus in their mouth and they'll just sit there with that in their mouth for the rest of the day, not realizing that they need to do anything with it. We are also oftentimes making recommendations to the patient to alter their rate of intake. And usually this is slowing everything down, because by coaching the patient to have a slower rate of intake and maybe putting into place some strategy to pace them to cue a slower rate of intake, it's going to give them more time to think about their mastication and their swallowing. It'll allow them more time to put if you have other recommendations into place. And this would be done pretty much as I mentioned just a second ago for those patients, specifically your traumatic brain injury patients, maybe your right hemisphere stroke patients that are just really so impulsive that they just bolt their meal down super quick. And you have to find some way of slowing them down. But one of the difficulties with this is that your TBI patients, your right hemi patients, they're going to have a lot of cognitive deficits. So are they even going to be compliant with you wanting them to slow down? Are they even going to be able to follow your recommendations to slow down? As I mentioned earlier in the semester, the last facility I worked at, there was a guy, an adult guy who had some sort of special needs. But he almost died out on a field trip from the nursing home because he basically bolted down this entire hot dog, just shoved this entire hot dog down into his throat and basically choked on it. And they had to take him to the hospital and revive him. Here are some strategies for slowing down the patient's intake, limiting their rate of intake. There is what is known as the Preval cup, and I mentioned this in a slide. I mentioned this a couple lectures ago. This is what they look like. It's a limited delivery cup. So patient turns the cup up like this, and it only lets out a little bit of fluid. So it cuts off the amount of fluid. The patient just can't turn it up and start chugging. They have to take a sip, put it down, take another sip, and put it down. If the patient doesn't have any pharyngeal swallowing problems, then teaching them to take small sips from a straw might be possible. As we already mentioned, putting the utensil down between bites could pace them. Teaching them to do a dry swallow between bites could pace them and also could clear any stasis. You could get together with OT and have a smaller spoon or smaller fork put into place so they're only able to feed themselves with smaller bites. So there's a lot of different strategies, a lot of different ways that you could come at pacing the client as they eat and trying to slow them down. So one of the first things you do when you walk in to evaluate a client's swallow is that you're going to look in their mouth as a part of their oral motor evaluation to see what kind of dentition they have. You're going to check the strength of their mandible because you want to know how well they're able to masticate. Because if they can't masticate appropriately, then you're going to be recommending a mechanical soft diet or a pureed diet. That being said, I have evaluated plenty of people in the past that had no teeth, had no dentures, and were able to get through a normal consistency meal just fine. And they let me know that right up front. It's usually them saying something like, well, I have dentures, but I don't need them. I eat fine without them, and I don't like them. So they'll usually come out and tell you that. Also, patients with decreased motor ability in the oral cavity are going to struggle to keep dry, crumbly boluses together. So things like rice or cereal are going to be very difficult for them to keep in a cohesive bolus to move posteriorly for an effective swallow. In this case, the more wet, the more soft boluses are going to stick together better in the oral cavity. They're going to slide posteriorly better in the oral cavity. And they'll also probably stick together better during the pharyngeal swallow. And there's a lot of Jell-O in hospitals for some reason. And to put it on your radar, Jell-O is a weird thing. It's best to think of and treat Jell-O more like a thin liquid than it is a solid food. So anytime you alter the diet of a patient, if they're getting sent home with those diet modifications in place, then you want to be sure that you are educating and maybe even over-educating the patient and the family on how to manage their consistencies. Because oftentimes you'll find that the families and the patient, they'll adhere to your recommendations in the facility, but once they go home, their compliance might break down a bit. So you might need to really over-educate them, emphasize to them the importance of your recommendations. And also, as I mentioned earlier in the semester, anytime you change the consistency of a patient's diet, anytime you change their diet whatsoever, you need to be sure that that patient is still going to be eating. Because if they can just as easily become non-compliant and refuse to eat what you have recommended. And if they stop eating, then that becomes a medical issue, and that is not something you want to be responsible for. So you would have to take a different route in dealing with that patient.